Hi friends, welcome back to this channel. It is the weekend of the AHA conference in New Orleans, and I'm always excited when these conferences happen because there's usually some pretty important studies that come out of them that change practice in our field of cardiology and the drugs that we use every day. Even though I'm not attending this conference, and I've actually never been to the AHA to be honest, I'm going to talk about a few of the studies that they're probably going to highlight and some of the results that they're finally going to reveal, and talk about some of the new drugs that you might not be aware of. First, I'll talk about the oral PCSK9 inhibitor called Enlictide decanoate in the Coral Reef trial. So we know that patients who have really high cholesterol often will need to be put on something more than just a statin and more than ezetimibe. So they are sometimes prescribed what we call an injectable PCSK9 inhibitor, such as Repatha, or gosh, what is the other one? It's called alirocumab. I can't remember the trade name. But anyway, how it works is that normally we have this protein called PCSK9 in our bodies that break down the LDL receptor on our liver cells. So when your body breaks down the LDL receptor on your liver cells, you have less of those receptors to sort of take in the extra LDL cholesterol in your blood. So the result, you end up getting more LDL cholesterol floating around in your body and wedging themselves into the blood vessels that we ultimately don't want. So what the PCSK9 inhibitors do is that they inhibit the protein so that they cannot break down the LDL receptors. So therefore, you have more LDL receptors to take in the LDL cholesterol for your body to ultimately get rid of that LDL cholesterol properly. So this leaves more LDL receptors to clear out the LDL from your blood. So the idea is that it'll offer an effective way to, and a non-injectable form of achieving aggressive lipid lowering targets like you would with Repatha. It's a phase 3 randomized double placebo-controlled trial with over 2,700 participants who have high cholesterol, who also have high cardiovascular risk. The primary endpoint is a change in LDL from baseline until 24 weeks. If you've been following the news on any of this stuff, the top-line results have already announced that the trial had met all of its primary and secondary key endpoints. So there shouldn't really be any surprise, but what I am curious to know is the magnitude in which it can actually drop the LDL numbers. Whether they would be as good as the injectable form, that would be surprising for me. One of the key complaints that some people have with the PCSK9 inhibitors are the injections that they have to give themselves every few weeks or so, or every month. And I'm excited. It's kind of like how semaglutide has its oral form that was studied in the SOUL trial that was recently published a few months ago as well. I can't imagine there being any crazy safety concerns about this, but we'll see. Next, I want to talk about the Surpass CVOT study, the actual outcome study that looks at tirzepatide compared to dulaglutide. Tirzepatide, which some of you know, is more than just the GLP-1 agonist, but it also has a second mechanism called the GIP, which is the glucose-dependent insulinotropic peptide. So compared to dulaglutide, which is just the GLP-1 agonist. So we know that GLP-1 agonists like dulaglutide, semaglutide has already some data for reducing cardiovascular outcomes in patients with type 2 diabetes and pre-existing heart disease. And we know that for tirzepatide is that it's been able to show better glucose control compared to just a GLP-1 agonist alone. So what this study is to try to figure out is whether tirzepatide actually maintains the established cardiovascular benefit, and more importantly, whether its better sort of metabolic effects translates to a better reduction in cardiovascular outcomes compared to just GLP-1 agonists alone. So we're hoping that this study will show they have more cardiovascular benefit beyond just glucose lowering as well as weight loss compared to a GLP-1 agonist. It is a prospective randomized open label study. So we talked about open label studies before in type 2 diabetics with high cardiovascular risk. Patients are randomized to a maximally tolerated dose of up to 15 milligrams of tirzepatide, dulaglutide 1.5 milligrams once weekly. as an injection. The primary endpoint is time to first occurrence of the 3-point MACE event, which is the cardiovascular death, MI, or stroke. And what we sort of know already is that the trial has already met its primary endpoint for the non-inferiority against dulaglutide. But what we're hoping to see is sort of the full presentation of its superiority for its MACE reduction, as well as some of the other things that we know it probably does to, like lower the A1C, weight loss, maybe even better blood pressure control as a result of all like the weight loss and such. Now, tirzepatide will be confirmed to be safe for patients with cardiovascular risk reduction. So overall, I think that tirzepatide is going to shine and will be confirmed as being a great drug for cardiovascular risk reduction and will likely show all the better metabolic stuff as well. So next, I'm going to talk about the strategy of using a drug to have an ultra early clot busting mechanism for STEMIs. So the trial is called Celebrate, and the medication, and I have to read this, it's called Zalunfiban, and they give it en route to the hospital. It's a subcutaneous form of a GP2B3A inhibitor, such as like epciximab or tirzepatide, which we hardly ever use now anyway. Those are intravenous forms of an antiplatelet medicine that is used for like bailout therapy in the time when they're doing an angiogram and doing some stenting. So the problem is that for STEMI patients, time is muscle, and delays in getting the patients to a cath lab for primary PCI means more damage. So the idea is that if you give this Zalunfiban through a subcutaneous injection en route, so giving first responders access to this, the idea is to give them as much antiplatelet effect or benefit early on compared to oral antiplatelet medicines like clopidogrel or ticagrelor, and thereby preventing the growth of that early platelet-rich thrombus to improve blood flow and to overall hopefully minimize the ischemic burden even before the patient arrives to the cath lab. It's a phase 3 prospective double-blind placebo-controlled trial in the pre-hospital setting. The primary endpoint is a composite of both efficacy and safety outcomes. And from what I know is that the top-line results are already positive, and I expect that the full data to show benefit in things like microvascular perfusion, maybe potentially lowering MACE at 30 days, and hopefully a more favorable or better safety profile in terms of bleeding. If this trial can demonstrate a fairly significant lowering of MACE events while also not increasing bleeding risk, I can see this being something of benefit and might actually change practice. Next, we'll talk about anticoagulation after atrial fibrillation ablation. So this is the OCEAN trial where they compared rivaroxaban against aspirin for people who are about a year out from their ablation procedure for atrial fibrillation, provided that they're stable and they don't have any recurrence of atrial fibrillation. Because the thought is that maybe once you ablate them and they don't have AFib anymore, maybe they don't need to be on anticoagulants ever again. That's the hope. But we do know that people who get ablated, it's not always a perfect solution. Sometimes the atrial fibrillation still kind of comes back because the underlying cause has not been addressed. But this trial looks at whether you can downgrade from an oral anticoagulant to an antiplatelet once the atrial fibrillation is pretty much completely gone. And so, meaning that if the AFib is gone, do they really need long-term oral anticoagulation? I sometimes get this question from the audience members in this channel. So this study would be very interesting to see what their results show. The OCEAN trial tested high-risk patients, so those who have a relatively high CHA2DS2-VASc score. They looked at the primary outcome of stroke, systemic embolism, and covert stroke detected on brain MRI at 3 years. So here's my prediction is that given that the stroke risk is based on persistent underlying risk factors like high blood pressure, diabetes, and some heart failure maybe, and not just AF burden, I would think that there are probably benefits to continuing anticoagulation compared to just aspirin alone. The thing is that we know aspirin carries a fairly high bleeding risk in itself too. So if you're looking at safety at a secondary outcome, it's probably not going to look that much different compared to the oral anticoagulant. So I think what the study will ultimately show is that rivaroxaban will just keeping them on an oral anticoagulant is probably going to be the right choice in reinforcing what we already do, despite a successful ablation. Last but not least is the trial name is called CTX310. So this is probably the most exciting one out of the bunch. This is why I saved it for last. And it's gene editing for refractory dyslipidemia. So some of you probably already have heard of CRISPR gene editing. So I've been nerding out a little bit a few months ago where I looked at CRISPR gene editing for cardiac amyloidosis. So the idea of being able to give an injection to somebody and then pretty much obliterate and just get rid of this portion of their genome that is a causative factor to their underlying disease is, so the idea is to use this CRISPR gene editing targeting something called the ANGPTL3, which is a protein that inhibits the enzyme that helps to break down fats or lipase. What's really cool is that some people with a natural loss of function mutation of this particular gene is that they have very, very low levels of LDL cholesterol as well as triglycerides. And they also have significantly lower atherosclerotic disease. So the idea is that if you can give this one shot gene editing that could be delivered to your liver and to permanently knock out the ANGPTL3 gene, you can mimic the cardioprotective effects of this gene mutation that some people have, and then you basically have like lifelong lipid lowering. So it is just a phase 1 open label study, and it's like a dose finding study to check for the safety and tolerability in patients with refractory lipid problems. What I do expect is that it's probably going to confirm some safety stuff, and more importantly, a fairly significant reduction in the ANGPTL protein concentration. This would be proof of the mechanism. And if successful, could pave a pretty crazy path for lowering MACE events for patients who have a lot of cholesterol that they just can't seem to nail down. So there you have it, 5 big topics and big studies that are probably going to be talked about at the AHA conference this weekend. And from a somewhat simple pill that's used to help lower cholesterol through PCSK9 mechanism all the way to gene editing for cholesterol. I'm excited, and stay tuned to the channel over the next few weeks as I'll try to do a deep dive into some of those studies that are presented at the AHA conference. If you are as excited as I am, hit that like button, subscribe, and remember to say no to drugs.